When do you turn from ALK-directed therapy to chemo? Particularly, let's dispense with crizotinib, but the second-gen agents we know are more effective, but do you have any confidence that brigatinib after alectinib is a high-yield change, or would you go straight to lorlatinib, or when do you stop going to the well, move to chemo, and maybe come back to ALK inhibitor therapy later?
So, I mean, that's a difficult question you're asking, again, because we don't really have clear data to guide us necessarily. I think if I'm done with alectinib and I don't think we're going to get any more clinical efficacy, my first choice would be to use lorlatinib, because I think the data in that setting is much stronger with that particular agent. But as far as when do you go to chemo and all that, there are a couple of scenarios. A, I've gone through 2 or 3 TKIs and all I get is progression after progression. It gets to a point where the tumor burden is too much or the patient is symptomatic and you want to get some disease reduction and reduction of the tumor burden. So clearly I'll pull the trigger on chemotherapy. And again, another patient population that benefits from platinum doublet based on all the data that we have using pemetrexed. So constant monitoring of the patient on DKIs to see if they're having responses or not. And if they're not and getting into trouble, to go to chemo is the way I would normally do it. And again, the whole issue with brain metastases becomes of paramount importance here, and how you have to continue to monitor it, because if they're progressing systemically and you're going from one TKI to another, there's a good likelihood that there could be brain progression, and you don't want to miss that. So I think it just makes management of this patient population a little bit more challenging in the absence of clear data.
Well, I think you raise a great point. As we have reached a consensus, I think, that for patients with brain metastases at the time of diagnosis, at least asymptomatic, if they have a driver mutation and specifically ALK-positive, we are increasingly confident that alectinib, brigatinib, lorlatinib all have good CNS activity, and we don't need to rush them to the radiation oncologist. But how does having somebody with a history of controlled brain metastases who's now progressing shape your choice of whether or if to move to chemo, where you may not have that? Or are you inclined to try to give both concurrently for these patients with an intracranial component of disease that's as much of a concern as the extracranial?
That's a very good question. And fortunately, it hasn't come up yet in my clinical practice, where I've had to think about continuing the TKI with chemotherapy. I think they've just had such florid progression. Either they've just had such florid progression that I've had to abandon one approach and go to the other, or they have not yet had such florid progression where I could just continue with the TKI and add in radiation, for example, for oligoprogression, with the oligoprogression paradigm. If I were to be in that situation, I just don't know if I have the data to safely deliver both chemotherapy and, let's say, alectinib or lorlatinib. I could presumably do it with very close follow-up, but that would be in a completely data-free zone.
Right, that's true. It's tough, and I think that having to worry a lot about intracranial disease would factor into our decisions about how long to stay in the EGFR-directed axis versus switching to chemotherapy. I mean, if we know that patients are at high risk for intracranial progression, we might linger longer with additional ALK inhibitor therapy. At least that's my view on it. There has been very little data on ALK-positive patients and their responsiveness to immunotherapy. Much of what scant information there is has been aggregating them with EGFR mutation positive patients. I would say, though, that we're getting a clearer sense that these are not the same population, that they're distinct, and that the ALK-positive patients, even with high PD-L1, are especially unlikely to benefit from immunotherapy. So what's your approach to how or if to use immunotherapy for the ALK-positive patients?
So again, I think we are blessed to have several different TKIs to choose from. With the recent approval of lorlatinib, that's usually what we will go to in the second, third line setting. I'm less inclined to use immunotherapy because of the paucity of data. I think if I was in a situation where I've gone through 2 or 3 TKIs, and now I'm in a setting where I have to use systemic therapy, I would prefer to use chemotherapy over using an IO, even if their PD-L1 level was high.
Would you be inclined to do a chemo-IO or a chemo-bev-IO combination for the ALK-positives based on the Empower 150 trial?
I think chemo-bev-IO would probably be a data-driven approach. I mean, it's a subset analysis that included ALK and EGFR mutant patients. So I think that could be theoretically and practically delivered feasibly.
Yeah, I think it's pretty much the same discussion we had with the EGFR patient population. I don't feel comfortable with single-agent IO.
Yeah.
I would consider chemo-IO plus bev possibly as an option. I would also argue that, still platinum doublet chemotherapy in this patient population post multiple TKI is still a very good option. And again, if there's a trial that combines a couple of different IO agents, I think that would be my preference if I'm going to go towards IO.
We've mentioned lorlatinib already, now FDA approved and with good data, not just in the minimally treated patients, but even in several patients who have had 2, 3, or more ALK inhibitors. Do you have experience using lorlatinib, and if so, what's been your experience in terms of tolerability issues? How broadly feasible is this, or are there toxicity concerns that community oncologists need to be aware of?
So I've used it on a trial. So far, I have not used it yet since the FDA approval. And I've not really had major success with it, unfortunately, just because I think it was in a much later line of therapy. It was on a compassionate use basis. And the patient was not on it long enough for me to really tease out the tolerability issues over time.
Yeah, we've had the study open also, but I didn't really have a patient on this drug, so I don't have any personal experiences dealing with it. But I know, talking to my colleagues, that they seem to be a very easy drug to tolerate, minimal toxicity. So again, looks like it's a viable option.
Yeah, I've used it in a limited capacity. I would not say it's non-toxic. There's different toxicities. The lipids, weight gain, and sometimes mental status, confusion issues. So nothing insurmountable, but there is a learning curve to it. So that'll be a bit of a challenge, I think, especially in a setting where most oncologists are not going to see a lot of these patients and have much experience using this. So it's just something, it's great to have another option available, especially one where you can see good activity even in such extensively treated patients. This has been extremely informative. Before we end the discussion, I'd like to get closing thoughts from each of you. Dr. Agarwal?
I would just say that this is an exciting time to be a lung cancer oncologist. I mean, every other week, every other month, we get another approval or we get another study that changes practice. I don't think in the past 10 years this has ever happened before, so more to come.
Yeah. Dr. Borgay?
I agree. I think it's a very exciting time to be a thoracic oncologist because of all the options that we have. And you really get the sense that you are beginning to help the patients have a better quality of life, live a little bit longer, and hopefully advance the science. I do feel bad for our colleagues on the NCCN guidelines that have to update their data almost constantly, but that's a great thing.
Yeah,
that's a great problem to have.
Champagne problem there. I think it's been amazing that in our time doing this, managing even metastatic non-small cell has gone from being an expectation of typically just months, and you take the gains where you get them, to now having the majority of our patients living beyond a year and thinking more about years of benefit, which is great, let alone the potential for curing more patients. As you bring up, we are having advances at such a terrific pace. It's been dizzying, and it's great, but it makes it even more of a challenge to get that information out to a broader population of general oncologists who are seeing 10 or 15 kinds of cancer a day. So very important, but it's again a great challenge to have. Thank you for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this OncLive peer exchange to be useful and informative.